Thank you, sir. And I will now request Professor P.C. Saxena, sir, to please introduce the speaker, Dr. A.K. Pandey, sir.
Well, I think Dr. Pandey doesn't need any introduction. He is a very renowned cardiologist of Delhi. He is the director of Max Super Specialty Hospital, Vaishali. He passed his DM Cardiology from the same institute from where I passed in 1979.
So you have been my examiner also, sir.
Thank you. That I don't remember, but it is very nice to see you here. He has a vast experience in intervention cardiology as an intervention cardiologist, and he is very interested in coronary artery disease, primary PCI, balloon mitral valvulopathy, etc. He has got a lot of achievements. He is member of practically all societies like European Society of Cardiology and Fellow of Cardiological Society of India and Fellow of Indian College of Cardiology. So with these remarks, I request him, Dr. Pandey, to present his oration.
Thank you, sir. Thank you very much. Colleagues from my fraternity, and really I feel so honored, obliged, and privileged to give this oration because I know I have been born and brought up from this city, Prayagraj, and I am from GIC Allahabad. So मेरे लिए Allahabad is always look an opportunity to come. का जो विवेक का अभिषेक का फोन है कि 12 मई को प्रोग्राम है, आपको आना है, तो मैंने ये नहीं पूछा मुझे क्या करना है. I said come, and I am more honored that my teacher who gave this degree and where I stand today as a DM cardiology is sitting as a chairperson. What can be more honor than for me? Thank you, sir. Thank you very much. When Abhishek asked me to speak something, dilemmas in cardiology. So I said dilemma will never end in cardiology. And despite having in cardiology for the last 25 years, every patient puts in a dilemma because it's a very dynamic and continuously upgrading process. You can never say, the day you say that you know everything, I think you are finished. So he asked me to speak something, what is dilemma in day-to-day practice? So I thought, let me realize what is my dilemma in practicing. Because every day we see 30-40 patients OPD. And I remember my boss, my HOD, Dr. H.S. Mittal, his very famous statement. Every patient is an examiner. बोला यहाँ तो मैं तुमको पास कर दूंगा चाहे तुम चाहे कितने गधे हो. But every patient will tell his symptoms, give his investigations, and ask you to diagnose. I think he is an examiner. And we still face the same dilemmas in day-to-day practice. And I have made all these slides by my own because there is no such topic which exists in cardiology, diagnostic dilemma. So you can see some things say overcried, the slides are not very that quality, but you know cardiologists and their technological skills. So I'll just go by important investigations which we see in clinics, and I think all of you see in clinic, and that one ECG leads to chain of questions and answers. What next? I remember when I was finishing my MD medicine and in transition out to become a cardiologist, every day was a dilemma. Patient has come with ECG. I left bundle branch block. I don't know what to do. What is the significance of this ECG? How to approach? How to proceed? And there came the history as a crux examination. This patient has come with left bundle branch block. और मुझे सर याद है कि अभी ECG रटने के लिए हमें कि W in V1, M in V6 is W. Because it was very difficult to recognize what is RBB, what is LBB. But since now machines have come with a lot of AIs and all that, the machine itself tells you diagnosis. And no machine has, I've seen any ECG machine has taken a normal ECG. Every patient ECG is abnormal. And that is the beauty of clinician. कई बार आते डॉक्टर साहब इसमें abnormal लिखा है, मैंने कहा abnormal नहीं है, लिखा है abnormal, अभी normal है ये. So this is what is your skill in clinical practice, because patient will come with anxiety. A lot of consultations come, जैसे ECG कराया तो उसमें abnormal लिखा है, मैं देखता हूँ नहीं यार abnormal नहीं है ये, हिंदी है ये, abnormal है ये इसको. So I'll just go back to a very important procedure which we did last week. The 88-year-old gentleman, though very frail but very fit, and a lot jail to survive. He had been given cancer, radiotherapy and chemotherapy. He had a recurrent syncopes. His ECG had a LV, left bundle branch block. So what message is that? A patient who has come with the left bundle branch block, he says he has a recurrent pre-syncope or syncope or recurrent giddiness, and neurologist says that this symptom is not because of neurology. I think this patient requires a pacemaker. So just by a simple left bundle branch block, you can conclude a patient who has a recurrent fall, syncopes, is he a candidate for pacemaker? So I'll just show what happened. So this, he was 88-year-old and he had, so we tried to put a pacemaker as a standard pacemaker below found that his both subclavians are blocked because of previous chemo, central lines, chemo and radiotherapy. So what is next? He has a recurrent syncope, he is a complete heart block, he is a left bundle blood block at the baseline. So we did a leadless pacemaker, that is Micra. And he is now 89, he completed his birthday, and he says that Dr. this therapy has changed my. So dilemma is there, should we proceed further, should we not proceed further? So it's not a diagnostic dilemma, it is therapeutic dilemma also. A procedure is 11 lakhs, each is 6-year-old, what to do? So dilemma is everyday practice you find such things. So same ECG, similar ECG. A patient has come, he can't walk few steps. I feel breathless. You take his history. जैसे रात को सोता हूँ मेरी नींद खुल जाती है. Classical orthopnea. He has a PND. Go into detail. He has multiple comorbidities. Same finding at ECG. I have ECG on one side with recurrent giddiness, syncope. Same ECG on other side as a breathlessness, orthopnea, PND, multiple risk factors. You go for an echocardiography, you find that this patient has a very poor LV functions. So what you're dealing is, as Dr. Alok said, is a patient of cardiomyopathy. We start him on all the 4 drugs, beta blockers, ARNI, SGLT2, MR antagonist, go for his metabolic profile by iron therapies, go for his ivapadine, go all the cocktail of medications. If patient does not improve despite optimum medical treatment, I think he is a candidate for CRTD. So rate dependent, so there are sometimes a patient has come with emergency, has come to emergency, chest pain. You look at ECG, again same left bundle branch block is there. आपने बोला यार तुम्हारा ECG ठीक नहीं है, डॉक्टर साहब बिल्कुल चिंता नहीं करिए, पहले भी ऐसी था. So a baseline ECG showing similar changes in a chest pain. So see how much is helpful a single diagnostic tool, electrocardiography, and it's a real challenge which ECG is going to lead you in which direction. And suppose you're sitting in a clinic, you tell your compounder to do an ECG, he comes with left bundle branch block. I think it will lead to you the symptoms of syncopes, heart failure, or ECS or acute MIs. So ECG is very important first diagnostic tool in cardiology OPD which we see, and this leads to any left bundle branch block ECG if has prolonged PR interval or his right or left axis deviation. I think you are looking for trifascicular block. You must follow up because this patient is going to be a candidate for pacemaker therapy in the future. So this is something like you can see. The video is not running. Look at ECG, echo, hardly any contractility. LV is 20%. Wait for 6 to 8 weeks. If therapy is not responding, patient can afford. CRTD is really a game changer, I have seen. I have a lot of patients who have been doing implant, but we should never jump. A first interaction with you as a heart failure patient, never jump on CRTD. Give a full-blown maximum tolerable medical treatment for 3 months minimum. If patient does not improve, I think he is the candidate for CRTD. They are just showing, look at the LVB, such a poor heart functions this patient has. Hardly any contractility. Just globule heart. This is a patient which we did pacemaker last week. He was 74-year-old, did a classical left bundle blood block. You can see, broad QRS. He was on maximum medical therapy. Not improving. It's a very wide QRS. So we did a CRTD for him. You can see how the QRS is narrowed down. It is the best indicator for informing, your informer, that the patient has improved with your therapy. The narrower the QRS after implantation of device with the broad QRS before that, I think you have done a very good job. So a response to a CRTD can be from ECG also. So it's such a basic investigation, tells a lot of. Look at this, such a narrow QRS. Go back to this, such a broad QRS. And this is the device which we put. There are 3 leads, you can see right atrial lead. This is LV lead. So this is the main lead which causes synchronization. So the left bundle branch block is a desynchronization. So by putting a lead in LV, you are going to reverse the desynchronization. And we have seen that it gives to reverse remodeling. EF improves and patients have really class 2, class 1 and have better quality of life. Very common is, कई बार आते हैं कि डॉक्टर साहब मैंने ECG कराया था और जो डॉक्टर साहब उन्होंने बोला कि तुम्हारी राइट आर्टरी बंद है. Because ECG machine is showing right bundle branch block. और बेचारा बिल्कुल घबराए हुए आता है कि ये राइट आर्टरी बंद है. मैंने कि बिना एंजियोग्राफी के तो यार दुनिया में कोई नहीं बता सकता. And their anxiety, the moment you say it in 2 to 3% patients, right bundle branch block is a common finding and need not to worry. He is reassured. But the message is not over here. This is how we used to remember, we used to recognize RBBB. This is left bundle branch block. Very important is that is RBB with normal axis? Is RBB the right axis? Is RBB the left axis? Usually benign RBB is with normal axis. Of same right bundle branch block, look at the clinical scenario. Acute onset. We had seen a lot of patients in COVID era. Patient had been discharged. He comes to emergency. Acute onset breathlessness. You look at ECG, you find classical right bundle branch block with a straight pattern, and there is a S1Q3T3, very form flushed for pulmonary embolism. So an RBB acute onset can lead to pulmonary embolism, diagnosis pulmonary embolism. It's not only that, you have to go for echo, you have to go for so many things. Our patient has last week, a lady came for clearance. She was expecting 6 months pregnancy. Got a ECG done, showed a broad QRS with classical right bundle branch block. By and large asymptomatic. We always get an echo to rule out any structural heart disease. So any ECG findings should be matched with structural heart disease. And to surprise, she had a large ASD with 6 months antenatal. See, you can't close this ASD because of radiation and all that. And the fear of large ASD in pregnancy is what is a paradoxical embolism. Any DVT can cross right to left heart and can create. So the advice was that continue pregnancy under surveillance. Get your cesarean once the baby is matured, I think 36, 38 weeks. And once the peripartum period is covered, go for ESG closure. A similar ECG, a same ECG finding with normal echo would have been missed. A patient, so it can be an ASD, a marker for ASD, it can be a marker for polymorphism, or it can be a marker large anterior volume. I'll just share, so this is the ECG in the pulmonary embolic. You can see RSR, S1, Q3, Q3 and T3. He inverted a deep S and incomplete right ventricle. He was thrombolized because he had hemodynamically significant RV dysfunction. He had a PH, and I think so. One strip of ECG gives a lot of information to us. This is a boy, I'm just a 20-year-old boy, just I think 3-4 days back, came to emergency. He was first year MBBS student. Came with his 10-12 batchmates, they all had anxiety. Only risk factor which was, he was little obese and he had a smoke, he was a smoker, and आजकल दिल्ली और एनसीआर में गांजा चरस ऐसे चलते हैं जैसे कि हम लोग इलाहाबाद में छोले समोसे खाते हैं, सच कॉमन। मैंने उसके फ्रेंड्स से पूछा बेटा कोई ड्रग एडिक्शन है, उन्होंने बोला अंकल मुझे नहीं पता लेकिन कल इसने ड्रिंक जरूर किया था। सीधे ECG, one AVL, entire record, massive ST elevation, just 20-year-old boy. He was attended by some nearby hospital. He was loaded with antiplatelets, was given IV heparin. See the second ECG? ST elevation has settled down, but still RBB is there, right bundle block is here. He came to us in our hospital and we repeated ECG. Look at the ECG. In fact, we had doubted the nursing staff who had done ECG. ये तूने ठीक से किया ही नहीं है ECG. Such a change. You look at the first ECG, second ECG, and third ECG. We did an echocardiography. We could find a lady area was hypokinetic, and we were planning for an angiogram. When we did an angiogram, his LED was totally blocked, which was a thrombotic burden. Next day, we always young patient, we repeat certain metabolic parameters. What we call as metabolic health is homocysteines, and can you believe homocysteine was 400 plus. And now there are genetic markers, that is methionine hydro, it's very tough name, MTHR. There is genetic testing for hyperhomocysteinemia, which are routinely done in patients with young stroke and young MIs. Because if that is there, then he requires a lifelong treatment. So same ECG, LED block, 20-year-old, I think we must look into all these things. A very simple test is Holter monitoring. Everybody advises left, right and center, and 90% people can't interpret. वो नीचे की जो फुट नोट होगा उसका कि ये है फलाना है धमाका है, उसको देख के कहेंगे ठीक है यार, but it's very important test for every clinician, whether it's a general practitioner, physician or cardiologist. So once we advise a test, we must know how to interpret it. Otherwise there is no point of advising a test. So ECG, as you can see, you can pick up so many things. Most common is palpitation, pre-syncope, young stroke. A patient is 30 years, he has come with a stroke in neurology. Don't find anything. Please go for prolonged Holter recording. Probably he is a candidate for paroxysmal atrial fibrillation. And if you miss it, you are going to miss the treatment also. Because the treatment for paroxysmal AF is anticoagulants. Treatment for normal sinusitis is antiplatelets. So whole therapy changes depending on what you pick up and what you diagnose. So Holter is very important. Pauses. Normally you get pauses, but the pauses of more the pause length is, more is the poor prognosis. So 2 to 3 second pauses are normal. You have to look into what time the pauses are there. If they are during middle of night, during deep sleep, even first degree AV block, Venki back block, in a patient who had a very good sleep in a Holter should be ignored. It's very important. But any pause which is more than 3 seconds should be taken seriously. And I think he has either sinus node dysfunction, sinus syndrome, or he has an AB block, maybe a candidate for. If patient has a syncope, you find a pause of more than 3 seconds, I think he requires a pacemaker. A pauses less than 3 seconds, 2 to 3 seconds, first degree AB block, prolonged PR interval, even 2 to 1 AB block during deep sleep. I think we should keep a watch. There was a lady I remember, she was obese, classical OSA patient, classical obstructive sleep apnea. We got Holter then. Holter had showed intermittent 2:1 AB block with prolonged PR interval, and she had classical daytime snoring. We got her sleep study done, started a CPAP, a BiPAP. The day she reversed her OSA, repeated Holter, you found that everything was normalized. So OSA has to be ruled out in all those patients. So diagnostic Holter is very important. It's a very simple investigation. I think every city has now consultants and they're accessible to Holter monitoring. It is not important that what is accessible. It is important that how do you interpret it. Getting everything is very important, but getting interpretation is, I think, is a very important one. There is a term called, I think Dr. Alok had discussed, tachyarrhythmia-induced cardiomyopathies. Again, Holter is going to help you out. This term has been coined in 20th century. Why it is important that it is totally reversible. It is one cardiomyopathy which if you control the arrhythmias, you reverse the arrhythmias, you are going to reverse the disease process. Otherwise, he will have a continuous elbow dysfunction, remodeling, dilatation, left bundle band block, and ultimately you will put a CRTD, which could have been avoided by just looking at his baseline ECG and his Holter monitoring. Maybe you may need prolonged Holter monitoring, maybe 2-3 days, or extended ELR, what you call extended loop record, and to pick up the diagnosis. And in commonest patients, suppose a young boy has come 18-year-old and the LV is 18, is 20%, you must rule out junctional atrial tachycardia. There are a lot of patients who come, Doctor, मेरा heart rate 130-135 ही रहता है. Their baseline heart rate is there. To rule out regular like thyrotoxicosis and hyperthyroidism, but other than that, go for his at least 48 to 72 hours Holter recording to look at occult arrhythmias which you may not be seeing on OPD practice. Similarly, I had a patient who had a chronic AF with fast ventricular rate, had a severe mitral stenosis, LV was 20%. She was not on optimal medical treatment. We gave a very good treatment by reducing heart rate, by digoxin and by beta blockers, by diuresis. You will not believe after 6 months of good control of heart rate, her EF had gone to 50%. Now, from high risk surgery, you are bringing up your patient to low risk surgery. So that is the beauty of controlling heart rate in a simple atrial fibrillation, because AF with fast ventricular rate is the commonest reason of arrhythmogenic LV dysfunction. Many times we get an Holter, we find that there is ectopic beats. To what extent they are important? If your Holter shows more than 20,000 beats a day, that is more than 25% of beats are ectopic beats. In total beat, I think this patient is going to land up in tachyarrhythmia-induced cardiomyopathies. So you are finding alternate BPCs or atrial arrhythmias, we should not leave it. We should give maximum treatment. Otherwise, this patient is going to land up in cardiomyopathy. And they have shown that cardiomyopathy can develop as low as 5,000 beats in 24 hours. That is a 5% of beat. So we should never ignore these extrasystole extra beats, because ultimately not treated, the patient is going to have LV dysfunction, and that is what we call as tachyarrhythmia-induced LV dysfunction. How to differentiate between two? Is it a dilated cardiomyopathy, or it is tachyarrhythmia-induced cardiomyopathy, or your patient had been very stable for heart failure or any disease. Suddenly you find that he is breathless, he has deterioration of symptoms. On clinical ground, you find that everything looks fine, but he has definitely gone down. His NT-proBNP has gone up. Please look at his occult arrhythmias. Maybe he has paroxysmal layup, maybe he has paroxysmal BPCs, which is loading his heart and causing cardiomyopathy. So unexplained deterioration in a clinical symptom, the patient who had been erstwhile stable, please look for his any underlying rhythm disorder. So that is the beauty of Holter. Holter is just like a very routine test. We advise left and center, and many times we just see 3-4 lines. हाँ ठीक है यार, कुछ नहीं करना है इसको. उसने बोला यार डॉक्टर साहब मेरे 5,000 रुपए लगे, देख तो लो ढंग से इसको. So we must always see the investigations very thoroughly. How to differentiate between a very grossly dilated LV doesn't favor tachyarrhythmia use. If you find that LV dimensions are less than 6, I think you must rule out what you call as TCMP, tachyarrhythmia induced cardiomyopathy. You can get MRI. Cardiac MRI is very much diagnostic for it. Virtually rules out between DCMP and TCMP or ischemic cardiomyopathies. We are using cardiac MRIs for looking at etiology also. So why it is important? Because if we pick up this, we are going to reverse his LV disorder. So that is the beauty of Holter monitoring. Very common finding in echocardiography. I still remember a patient, मेरे गांव का मेरे ट्रैक्टर का ड्राइवर था वो, तो उसको हम लोग आई वॉज इन क्लास 12th, तो उसको कार्डियोलॉजिस्ट को दिखाया, उसने इको किया, उसका वॉल लीक कर रहा था. तो बेचारा बड़ा दुखी आया. मैंने कहा क्या हो गया, क्या बड़े परेशान लग रहे हो. बोले डॉक्टर साहब गए थे डॉक्टर पे, उन्होंने बोला तुम्हारा वॉल पीछे ठोक रहा है, रिवर्स्टेशन. अब आई रिमेंबर नाउ एज ए कार्डियोलॉजिस्ट, ही हैड वेरी माइल्ड MR, mild AR, trivial TR, sclerotic aortic valve. All these things we should take with a pinch of salt. पेशेंट आते हैं डॉक्टर साहब, उन्होंने बोला वॉल्व मोटा हो गया तुम्हारा. तो मैंने कहा इको रिपोर्ट दिखाई. It is atherosclerotic valve, which is very common in 6th or 7th decade patients. Should we interpret? So with atherosclerotic valve should be taken seriously. Is it a bicuspid aortic valve? Because that is the valve which is going to progress in aortic stenosis much more than a tricuspid aortic valve. So minimal regurg, trivial TR, a normal PA pressure, mild pericardial effusion, not causing any diastolic collapse, sclerotic aortic valve disease, I think we just reassure patient, because the machines are so sensitive that they can pick up even whiff of blood on either side. So we must ignore. What we have to take seriously is chamber dilatation. A patient has a cardiac enlargement and then there is regurgitation or stenosis. I think this patient has a significant valvular heart disease. Otherwise, just a routine, maybe more meticulous, have a regular follow-up, maybe 6 months or maybe a year. So we should ignore any PH. A patient has come for a different reason, especially heart failure with preserved EF. It's very common, HFpEF is a very common discussion in all the, conferences. So a patient who has come with, he is hypertensive and you go for echocardiography, you find diastolic dysfunction, but any amount of pulmonary artery hypertension, if it's present, I think he has a heart failure with preserved EF. So pH has to be taken very seriously. Presence of pH, presence of atrial dilatation, or what I have seen, a patient has a resting hemodynamics normal. We have advised them stress echocardiography for surgical clearance. They go for echocardiography, baseline echo shows it's normal. Then they go for exercise, and you find that once they do an exercise, they have grade 3 diastolic dysfunction, which was normal at baseline. I think they are the patients who are going to have heart failure with preserved EF, because sometimes exercises unmask the occult underlying diastolic dysfunction. So this is the algorithm. Everybody knows how to go for ref, FREF and mid-range and FF, so I will not go detail. Very common treatment is most important. Though I am interventionist, I do intervention cardiology, but I still feel cardiology is not only intervention, it is a total cardiology. Our TMT is a very, very good screening tool for patients who come to OPD. So there are criteria according to how much minute a patient has walked. So anybody who has walked less than 5 minutes is a poor tolerance, poor prognosis. 5 to 8 minutes is adequate, 9 to 12 minutes is good capacity, more than 13 minutes excellent exercise capacity. And positive predictive value of treadmill is very good. So I'll take just 2-3 minutes and that's all. So this patient had a very strongly positive treadmill. Few words about coronary calcification. A patient who has a treadmill positive, borderline you feel maybe positive, maybe negative, it's very common. You can have a coronary artery calcification. It's basically this is used either to bring down the patient low risk or patient to high risk. If coronary calcification is more than 400, I think he is in high risk. Less than 100, it is low risk. So depending on all these non-invasive tests, you can stratify your patients. I'll just give one example. A patient, he came with us with classical chest pain and he got his CT angio done. This is the treadmill. We advise him to go for an angiogram. He said, "Doctor साहब एंजियो नहीं करना है, एंजियो करते आप लोग छल्ला डाल देते हो." मैंने कहा कोई बात नहीं, तुम CT एंजियो करा लो. When he got his CT angiogram done, you can see his calcium score was 1127. 400 is acceptable, less than 100 is best, 0 is like no CT. So we got his CT angio. The CT angio shows that he had some disease, 66-70% in lady. RC had 40% and LC had 30%. When we got his angio done, you can see left system is normal, absolute reverse of CT angio report. There was nothing in left system. And when we got his RCA, you can see a very critical block in RCA. It was a thrombotic disease in RCA. अब वो पीछे डॉक्टर साहब जल्दी कर दीजिए. मैंने कहा मैं तो कल से बोल रहा हूँ तो मैं क्यों करो यार. So it's a good triaging also. So where we advise CT angiogram, when we presume that the patient will have normal angiogram, it is more for a negative predictive value. A normal CT angiogram virtually rules out CAD. But where we think that a patient has a critical disease, I never advise CT angiogram. So it is to rule out disease. So good combination of ECG and echo and I think Holter and markers, CT angiogram, coronary calcification, you can reach to 99% patients in diagnosis. Despite we have everyday diagnostic dilemmas. I think this will continue as long as we practice. Thank you very much for patient hearing and giving me an opportunity to be here in my hometown with my senior clinicians. Thanks to Abhishek who has been, I will not say my student because I don't deserve to be his teacher, but I think he's one who invited me here. And once again, thank you all. Thank you very much.
Thank you. This is an oration. The question and answer session is not allowed in this. If anybody has a question, he can meet Dr. in private and increase his or her knowledge. Thank you.
Thank you, Chairpersons, Speaker, Dr. A.K. Pandey sir. I will now request President IMA, Dr. Kamal Singh, to please come on stage to felicitate and honor the Speaker and Session Chairpersons. Dr. Ashutosh Gupta, please come forward. And I will request Secretary Dr. Abhishek Sachdeva to please join the President and Secretary. I will request Dr. V.K. Agarwal's family members, Dr. Sanjeev Agarwal sir and Dr. Kavita Agarwal ma'am to please come on stage to please felicitate and honor the Speaker and Session Chairpersons.
correctly.